So HCC is the fourth leading cause of cancer-related death in the world. The number of deaths per year in HCC is similar to the incidence throughout the world, which really highlights the high case fatality rate. Over the past years, several new drugs have been added to the drug armamentarium, and today we'll discuss about all of them. So in general, when we talk about HCC, it is a multidisciplinary team evaluation. Most importantly, you want to evaluate the underlying hepatic function, the hepatitis B virus and hepatitis C virus status. You first want to assess for curative treatment options. That is really critical. Our previous speakers spoke really well about the role of resection, transplantation, radiofrequency ablation, and SBRT will be coming up soon. You want to understand the indication and the institutional expertise of regional therapy. You heard about TACE, radioembolization, and I will talk about the role of molecular targeted therapy, the indications, doses, and the side effects, the role of immunotherapy. You always want to encourage your patients to participate in clinical trials, since unfortunately this is a disease that has a high mortality. So yeah, I think you've seen this image several times through the morning, and it is the most practical way to look at staging of HCC. And today I'll be focusing mostly on the advanced stage C, where patients have portal invasion, extrahepatic spread, but still have some preserved liver function and have maintained their ECOG performance status to 1 to 2. So when we talk about systemic therapy for HCC, we talk about molecular targeted therapy and immunotherapy. And then at the end, I'll talk about some of the ongoing clinical trials. So if you look at the treatment landscape, the approved first-line systemic therapy options are listed below. Sorafenib was one of the first ones that was FDA approved in 2007 for unresectable HCC in the SHARP trial. And there was also an Asia-Pacific trial. Later, lenvatinib was studied in the REFLECT trial, where it was studied in a non-inferiority fashion with sorafenib, and it was approved for first-line treatment of patients with unresectable HCC. And then more recently, exciting data from the IMbrave 150 trial, where atezolizumab, which is an immunotherapy drug, was combined with bevacizumab, which inhibits angiogenesis, and this was approved in the first-line setting. Nivolumab was also studied in the first-line setting, and although we did see some clinical benefit in terms of response rates and some complete responses, in terms of overall survival and progression-free survival, the pre-specified hazard ratio was not met, and it was considered a negative study, and that was Checkmate 459. So let's go to the basics. The phase 3 SHARP study looked at the comparison of sorafenib versus placebo in advanced HCC. And the common theme you will see with all the trials that I present is that most of these patients, in fact, almost all the patients had Child-Pugh A cirrhosis. So we have an unmet need in patients with a higher degree of cirrhosis like Child-Pugh B. Unfortunately, Child-Pugh C, because of their bad underlying liver disease, most of them are really suitable for hospice or palliative care. And so in this study, the primary endpoint was overall survival and time to symptomatic progression. And the dose was 400 milligrams twice a day. And before I show you the results, I just want to talk briefly about how sorafenib works. So on the left, you can see the tumor cell, and on the right, you can see an endothelial cell, which could be either a vascular or lymphatic cell. And in the pathways that are responsible for survival and proliferation of these tumor cells, there's several growth factors that are imperative for tumor growth. So sorafenib works on the RAS, RAF, and MEK and ERK pathway, and it inhibits survival and proliferation. And typically, these tumor cells have growth factors that bind to the receptors on endothelial cells. And you can see in the image on the right, you can see these growth factors binding to the extracellular receptor, and then they affect downstream signaling that affects angiogenesis, differentiation, proliferation, migration, and tubule formation. So in this study, you can see here, this was the overall survival. It was 10.7 months versus 7.9 months in the placebo. And this was highly statistically significant. And it was the first study to show overall survival improvement over placebo. You can see in the time to progression, again, a benefit 5.5 months versus 2.8 months. And this was also statistically significant. The important things to remember with sorafenib when you're taking care of these patients, the most common side effects that we see are diarrhea, hand-foot syndrome, and anorexia. Lower risks are bleeding and liver dysfunction. So a lot of education for the patients. We at AHN Cancer Institute have oral chemotherapy nurses who do a fantastic job calling the patients and making sure that they're following the instructions with moisturization of hands and feet and keeping up with their diarrhea management. So as you can see, the treatment for HCC from 2007 to 2017 was just sorafenib. And then we started looking at other tyrosine kinase inhibitors. And one of them is lenvatinib. And this is an oral multi-kinase inhibitor. It targets VEGFR 1, 2, and 3. It also targets FGFR 1, 2, and 3, and 4. And in addition, it targets RET, KIT, and PDGFR alpha. So this was studied in a non-inferiority study. It was a phase 3 trial of lenvatinib versus sorafenib in patients with unresectable HCC. These patients were all Child-Pugh A, BCLC stage B or C. They all had adequate organ function. And the patients who were excluded were those who had more than 50% liver occupation, clear bile duct invasion, or portal vein invasion at the main portal vein. So they did not have very, very advanced tumors. Just remember that, because when we talk about the I Am Brave study, that's where the difference was. ECOG performance status was 0 or 1. So these are a particularly good group of people. And they were randomized to either lenvatinib or sorafenib, and the primary endpoint was overall survival. And here you can see in the Kaplan-Meier plot here that the overall survival was 13.6 versus 12.3, and this was considered non-inferior to sorafenib. And you can see the overlap of the curves. In terms of progression-free survival, for lenvatinib, it was 7.4, and for sorafenib, 3.7, and that was statistically significant in favor of lenvatinib. But remember, that was not the primary endpoint. And if you look at the objective response rates, higher with lenvatinib at 24% versus 9% with sorafenib. Now, if you look at the historical sorafenib study, the response rates were only 2%. Here we see a 9% response rate. Why is that? Of course, this is a different study. Secondly, maybe the physicians know how to handle the sorafenib toxicities better, and patients are staying on sorafenib longer. But here you can see that, again, in the waterfall plots, there were some complete responses with lenvatinib, about 6 patients, and with sorafenib, about 2 patients. So at the end of the day, this was a non-inferiority study for lenvatinib versus sorafenib. However, lenvatinib had better objective response rates and a better progression-free survival. Some of the things to remember with lenvatinib versus sorafenib side effects: lenvatinib tends to give you more hypertension, and whereas sorafenib can cause more hand-foot syndrome. So depending on your patient population, if you have someone with uncontrolled hypertension, you probably would want to go with the sorafenib pill. And if you want to avoid hand-foot syndrome, you could use the lenvatinib in your patients. Other side effects that I commonly see are diarrhea, and dysphonia is a common one where patients can develop hoarseness of the voice. Unfortunately, there's no treatment for that. So just give them a lot of TLC and try to get them through treatment. Hypothyroidism is something that people forget about. So we always check a baseline TSH and continue to follow it along the way every 8 weeks. So next, we'll talk about nivolumab. This is an immunotherapy drug, a PD-1 inhibitor. And so our previous speakers had spoken a little bit about immunotherapy. But typically what nivolumab does is it blocks the interaction of PD-L1 that is expressed on tumor cells with the PD-1 that's expressed on T cells, and it inhibits all the signaling processes that cause immune suppression in the tumor environment. And therefore, it increases the number of T cells that then go ahead and attack the tumor cells. So nivolumab was first tested in this study called the Checkmate 040 in patients with advanced HCC. This was a phase 1, phase 2 dose escalation study, and they included uninfected patients. They included patients with HCV, patients with HPV, and also patients who are sorafenib progressors and sorafenib naive patients. And they went from a dose escalation study to the dose that we use now, 3 milligrams per kilogram in the expansion phase. So here you can see the change in the target lesions from baseline in all the different subtypes: uninfected patients, HCV patients, and the hepatitis B virus patients. And the ones with the asterisks are the ones who had a partial response. And you can see we also had 3 complete responses in this phase 1, phase 2 study. If you look at the objective response rates, about 15% with 3 complete responses. This was in the dose escalation cohort. We also did not see any correlation between PD-L1 expression and response. And in the expansion cohort, again, responses occurred regardless of the PD-L1 status, and the response rates of about 16% with 2 patients who had a complete response. So, we always ask the question, what about my Child-Pugh B cirrhosis, B7? What do I do with that patient? And, there's very little data, but this is a study, a very small study in patients with advanced HCC, Child-Pugh B naive or experienced. There are about 49 patients here who were exposed to nivolumab, 240 milligram every 2 weeks, and until progression of disease or unacceptable toxicity. And here you can see that they included BCLC stage B, C, and D. Most of them were C. Child-Pugh classification B7 was in 76%, and 22% had B8, and half of them had received sorafenib prior. And here you can see, again, it's a small study. In blue, you can see the sorafenib naive patients, and in red, you can see the sorafenib treated patients, and the bars below the line are the responses, and the bars above the line are the ones who progressed. And then on the right, you can see how the tumor burden changed per investigator assessment. And this is a spider plot that shows in green the patients with stable disease, in purple the patients who had a partial response, and then you can see in blue are the ones who progressed. So you can see that we still saw some responses, but the question always remains, how did they do with this treatment with their bad underlying liver disease? So the treatment-related adverse events were manageable. The rates of discontinuation due to adverse events were not higher than the Child-Pugh A cohort. The hepatic adverse events were not higher in the Child-Pugh B cohort versus the Child-Pugh A cohort. The objective response rates were about 10%. Median overall survival, if you look at all the patients, naive or treated patients, 7.6 months. For the sorafenib naive patients, it was 9.8 months. And for the previously treated patients, it was 7.4 months. So I think in carefully selected patients with a good performance status, you could consider using nivolumab. Now, Checkmate 459 was a study that compared nivolumab versus sorafenib as a first-line treatment in advanced HCC. This was a randomized open-label phase 3 trial. And again, patients had Child-Pugh A disease with a good ECOG performance status, and their primary endpoint was time to progression and overall survival. And here they received nivolumab versus the standard dose of sorafenib, and they were all treated until progression of disease or unacceptable toxicity. So here you can see the graphs for overall survival and progression-free survival. You can see a slow widening of the curves here. The median overall survival was 16.4 months versus 14.7 months. The progression-free survival was 3.7 months versus 3.8 months. And Unfortunately, the predefined threshold of statistical significance for overall survival with nivolumab was not met, although nivolumab did demonstrate clinical benefit in terms of objective response rates. For nivolumab, 15% versus sorafenib, 7%. So this was a bit of a disappointment. Although we do see some response rates, the endpoints of overall survival and progression-free survival were not met. Next, I'm going on to the IM-BRAVE 150 study. This was a study utilizing atezolizumab with bevacizumab versus sorafenib for first-line treatment of HCC. So atezolizumab is a PD-L1 monoclonal antibody that works similarly to nivolumab, and I had shown you the mechanism there. And so you have to be very cognizant of the potential adverse events with immunotherapy. When you say immunotherapy, what happens is you have all these T cells running around in your body and attacking your organs, and not only the tumor cells, but it can attack your other organs. So you could develop colitis. You can get all the itises that patients can develop with an autoimmune disease. So dermatitis, colitis, thyroiditis, you could get hypopituitarism. So these patients need to be monitored very carefully and on a regular basis. And bevacizumab is a drug that's been around for a long time, has been used in treating several other cancers like colon cancer. And so the way it works is it's a monoclonal antibody to VEGF-A, which is vascular endothelial growth factor, and it inhibits angiogenesis. So some of the potential side effects to remember are hypertension, risk of wound healing problems. So you have to wait at least 4 weeks after surgery to initiate bevacizumab. There are also risks with the bowel perforation. And in this situation where you have HCC and patients have varices, you have to worry about variceal bleeding. And in this study, patients were required to have an EGD, an assessment of varices and treatment of varices if needed before going on this clinical trial. So having said that, the initial trial that was looking at atezo and bev was the GO30141 trial, which was a randomized phase 1b study that did show a potential benefit in patients with advanced HCC. And the objective response rates in that phase 1b trial was about 36%, which was the highest that we've ever seen. And that is why we embarked on this phase 3 trial. These patients had locally advanced or metastatic and or unresectable HCC, and with no previous systemic therapy, Child-Pugh-A, and a good performance status. So in this study, the co-primary endpoints were overall survival and progression-free survival. And this trial included subgroups of high-risk patients, which, if you recall, I said in the lenvatinib study, they did not have high-risk patients. So 40% had macrovascular invasion and specifically included patients with 50% hepatic involvement or main portal vein invasion or invasion of the portal vein branch contralateral to the primary involved lobe. So atezolizumab and bevacizumab were compared with sorafenib and treated until progression of disease or intolerable toxicity. So here you can see the overall survival on the left. At 6 months, 85% were alive in the tezo-bev arm versus 72%. And it was not evaluable at the time of the presentation. Sorafenib, the overall survival was 13.2 months with a hazard ratio of 0.58, which was highly statistically significant. The progression-free survival between atezo-bev and sorafenib was 6.8 versus 4.3 months with a hazard ratio of 0.59 and statistically significant. And if you look at the objective response rates, 33% versus 13.3%, which is not too far from what we saw in the phase 1b study. Complete response rates of 10% versus 1.9%. These are updated from ESMO. And the median follow-up was 8.6 months. So very excited to see these results for our patients. If you look at the quality of life that was patient reported, again, you can see the median time to deterioration of disease and quality of life. With the atezolizumab and bevacizumab, it was 11.2 months versus 3.6 months in the sorafenib arm. So another plus for our patients maintenance of quality of life. If you look at the safety, on the left are the atezo-bev bars, and on the right are sorafenib, and you can really see just by looking at this that the patients on the atezo-bev arm had fewer all-grade adverse events and grade 3 to 4 adverse events, except for hypertension, which is easily manageable. The other important things to remember, like I said before, EGD within 6 months of initiating treatment was required to evaluate for varices, and varices of any size according to local standards of care had to be treated. Upper GI bleeding rates in atezo plus bev versus sorafenib groups was 7% versus 4.5%, and this was consistent with historical data that we see with bevacizumab. Another study was was interesting is the durvalumab and the tremelimumab in unresectable HCC. It's a mouthful of words, but these are also immunotherapy drugs targeting PD-L1 and CTLA-4. This was a randomized phase 1-2 trial in which patients with unresectable HCC with progression or intolerance to sorafenib with or without hepatitis B or C were treated for 4 doses and then with durvalumab monotherapy. And here you can see in the waterfall plot, you see some good responses in the uninfected and also in the hepatitis B and C virus patients with confirmed objective response rates up to 25% in this population. So the phase 3 trial is the Himalaya study. That is a multi-center randomized open label phase 3 trial, also looking at these combinations versus sorafenib, and the primary endpoint is overall survival. The final results of this study have to be still presented, but the initial results seem to show that the combination has a favorable safety profile, and it met its primary endpoint of overall survival versus sorafenib. And also durvalumab monotherapy met the overall survival endpoint of non-inferiority versus sorafenib. And so the final results are expected soon at an upcoming meeting. In terms of second-line options, we have several here. And you can see, again, all of them are in Child-Pugh A category. And cabozantinib in the Celestial trial, nivolumab, we already talked about. Pembrolizumab was looked at 2 different trials. Ramucirumab was looked at specifically in all patients and then eventually approved in patients with AFPs of more than 400. You have regorafenib, and then the IPI and Nivo combination was also looked at an arm in the Checkmate 040. So quickly going through this, Keynote 240 compared Pembro to placebo, and it was Child-Pugh A. And this was in previously treated. So we're talking about second line now. Co-primary endpoints were PFS and overall survival. Unfortunately, we did not meet the pre-specified level of statistical significance for OS and PFS. However, objective response rates were higher with Pembro versus placebo, 18% versus 4.4%, and this was statistically significant. And the median duration of response was also very long, 13.8 months. This is the IPI-Nivo combination. And here they used 3 different types of dosing. And you can see that arm A, 22.8 months overall survival. And that was a combination of Nivo 1 and IPI-3 dosing. So that was very exciting. But remember, Checkmate 040 was a phase 1, phase 2 study, and the phase 3 trial is ongoing. Ramucirumab binds to VEGFR2, and this was studied in the REACH study originally. They saw that there was a signal in patients who had an AFP of more than 400. So they compared ramucirumab versus placebo, and the primary endpoint was overall survival. And here, a modest improvement in median overall survival of 8.5 versus 7.3 months. Not very exciting, but still, this is an option for patients. Progression-free survival, 2.8 versus 1.6, and this was statistically significant. So that is approved for patients with an AFP of more than 400. Regorafenib is another TKI that targets multiple protein kinases and VEGFR1, PDGFR alpha, FGFR1 and 2. And this was studied in the RESOURCE study and in Child-Pugh A liver disease. So it was rego versus placebo. Primary endpoint was overall survival, and the median overall survival was 10.6 versus 7.8 months. And the progression-free survival was 3.2 versus 1.5 months. So this was the first agent proven to be of survival benefit after failure of sorafenib. With TKIs, we talked about the various side effects of hypertension, bleeding, changes in liver function tests. Cabozantinib versus placebo was studied in the Celestial trial, again, another phase 3 trial. This targets VEGF receptors, MET and AXL. And again, Child-Pugh patients, Cabo was compared to placebo in the second-line setting. And here you can see, again, median overall survival 10.2 versus 8 in placebo. That was statistically significant, and also an improvement in progression-free survival. So another option for our patients. So coming to the important slide of sequencing, how do we sequence all these drugs? So you have atezo-bev, which is now considered the first-line therapy for our patients, unless there's a true contraindication, such as with atezo. You need to be careful. If a patient is a transplant patient, you cannot give atezo. If they have an autoimmune disease that is uncontrolled, you cannot give atezo. There are select cases of patients who have autoimmune diseases that are well controlled. You can consult with a rheumatologist and you could challenge them with atezo, but again, it's a case-by-case basis. Lenvatinib and sorafenib are considered also first-line therapies that you can give to your patients. And if you progress on atezo and bev, what do you do next? Do we have any studies that have looked at second-line lenvatinib or sorafenib? And I'll talk about a retrospective study that was just published recently that does show some benefit of using lenvatinib or sorafenib second-line, and also with manageable side effects. Now, what about second-line therapy after you progress on sorafenib? We talked about all the drugs, rego, ramu, and cabo. What is apatinib? This was studied in a Chinese population and was looked in the second-line setting for Child-Pugh class A or B less than 7. It's not available to the US population. Pembro, we talked about the studies with Pembro only for Child-Pugh class A second-line, Nivo again, class A or B7, and then Ipi-Nivo for class A only. Donafanib was recently published. It was a study, again, exclusively Chinese population versus sorafenib in first line. And it is a sister drug of sorafenib, except that it has a better pharmacokinetics. And the difference in survival was 12 months versus 10 months. So I think that in the Chinese population, donafanib may become the first-line therapy. We will see in the future. This is the retrospective study that looked at progression after first-line atezo-bev. This was a multi-center retrospective study in patients from Korea, Hong Kong, and I think Singapore. 71 patients were treated with atezo-bev, 49 received subsequent therapy. Of them, 29 received sorafenib, 19 lenvatinib, and 1 received cabo. And they were all Child-Pugh. Objective response rates were 6.3%, disease control rate of 63%, and overall survival of 14.7 months, which is quite impressive. If you look at the separate lenvatinib and sorafenib data, it looks like lenvatinib is more favored compared to sorafenib. And in terms of adverse events, any grade adverse events were seen in 85%, grade 3 in only 16%. And the common things we see are hand-foot syndrome, fatigue, hypertension, diarrhea, and these are easily manageable. So the conclusion of that study was that second-line treatment with TKIs showed comparable efficacy and manageable toxicity. So this is just the phase 3 trials that we talked about. So in general, you can see in the second-line setting, we get an average median overall survival of 8.7 to 10.7 months. And then the key phase 3 trials with immunotherapy for first-line treatment of advanced HCC are listed below, and you can see there are various combinations of TKIs with immunotherapy. And so we're looking forward to the results of these trials so that we can help our patients. Some of them have response rates higher than 35%, so lots of hope in the future for our patients. And then the last slide is, my husband has been nudging me for a while now. So the last slide is adjuvant therapy and combination therapy with local regional therapy. So we're really looking forward to the results of these trials where we're combining TKIs with immunotherapy, or immunotherapy combinations with TACE, or TACE compared to TACE alone, or compared to local ablation. And I think doing all these trials is going to increase the number of options that patients will have in the future. And I think this is my last slide. Research is to see what everybody else has seen and to think what nobody else has thought. So thank you very much for your patience, and I'm happy to take any questions.